Hello, dear colleagues. This is Mohammed Zaafrany, and I'm very happy to be with you today. First of all, I would like to thank you for being here and thank you for your interest. In the last lecture, I shared with you some basic rules to avoid shaping your errors, and I was very happy by your comments and your positive feedbacks. Today, the topic is different. It's considered continuity to root canal treatment procedures, with more focus on disinfection and 3D sealing to the root canal system. I hope it's going to be a very nice time for you with lots of benefits. Let's start.
Okay, so my today's presentation will be about the three-dimensional management of endodontic space. Many of you know that in 1917, Hess and his colleagues demonstrated the internal anatomy of the root canal system as a complex structure. And if you're interested in seeing the complexity of root canal system, you can follow the work of Dr. Marco Verzani and the Root Canal Anatomy Project website using the modern micro CT scans to get more familiar with the internal anatomy of the root canal system. Sometimes after our obturation, we can radiographically see how complex is the root canal system after filling of internal spaces, simply because it got filled and traced by filling material. Like in this case, you can see filled isthmus as a connection between mesial and distal root canal system. Also, you can clearly see filled lateral canals. And here, the connection between root canal system that mostly untouched with our mechanical instrumentation. We know that we rely more on chemical disinfection to reach and clean areas that untouched by our files. And mainly, we rely on sodium hypochlorite along with EDTA and sometimes chlorhexidine as irrigating solution. But we need to identify more the irrigation component, the irrigation protocol, the activation, final flush protocol, what is the anti-biofilm strategy, and how to remove smear layer. Before speaking about a protocol for disinfection, let me highlight more the importance of quality of irrigation needle. We know that it's mandatory to use a side-vented needle, but did you think about how important is the flow of the fluid from the needle? The fluid flow is the mechanical component of irrigation and the fluid dynamics. Here in this article about evaluation of irrigant flow in the root canal system using different needles types, the authors stated that the good fluid flow from irrigation needle will increase cleaning efficacy in the apical part, will improve irrigation replacement, and also will help in mechanical detachment of debris and tissue remnants. Here in this video, you can understand very well what meant by the good fluid flow from irrigation needle and how effectively it moves the debris from inside the canal to outside. So it is very important to break the barrier between good contact of irrigation solution and the contaminated dentine walls, involving the removal of smear layer that formed during mechanical instrumentation to the canal. Many irrigation activation techniques are known to clinicians and already incorporated in daily endodontic practice to improve the disinfection process, include sonic, air sonic, ultrasonic activation, laser PIPS, intracanal heating, negative pressure, or manual dynamic activation. But the most commonly used technique between endodontists is the ultrasonic activation, and it was already stated in literature the importance of passive activation using ultrasonics and how it improves the quality of debridement and irrigation penetration into the dentinal tubules. In the systematic review in 2019 about ultrasonic activation during root canal treatment, it shows that the ultrasonic activation is more effective than syringe irrigation regarding the removal of pulp tissue remnant and hard tissue debris. In this in vitro experiment on influence of irrigant activation, concentration, and contact time of hypochlorite into root dentine, it was already proved that manual dynamic activation, sonic or ultrasonic activation improve the penetration of hypochlorite into dental tubules compared to static irrigation by needles. And in this in vitro study, comparing the efficacy of ultrasonic activation and the novel method of irrigant activation. The author stated that ultrasonic activation will improve the pulpy tissue removal, hard tissue debris removal, better root canal disinfection, and overall improvement of root canal debridement. Another recent research in 2021 comparing various methods of irrigation activation and how effective is the procedure, the author concluded that when ultrasonic and sonic devices were used to activate root canal irrigant, organic substances in the isthmuses were removed more efficiently than when only needle and syringe were used to clean the root canal system. Some studies recommend ultrasonic activation to be 1 minute. Other studies recommend 3 to 5 minutes. So whatever the time, but it's already proved the importance of ultrasonic activation. Here I would like to introduce to you a new device from Fanta, the Actor Eye Pro, which is an ultrasonic device could be used for irrigant activation inside the canal. Here you can see the use of the device in activation of the irrigant, cleaning the isthmus, activation of irrigation in the distal canal, in another case of retreatment, where ultrasonic activation would help or removal of all the filling material from inside the root canal system. So this is what happened inside the root canal system during the ultrasonic activation process. Cavitation, which is formation of thousand teeny bubbles, which rapidly implode, producing a shock wave, removing the biofilm. Acoustic streaming fluid will absorb oscillating energy from the ultrasonic power, will introduce a powerful fluid flow inside the root canal system, which will help in better debridement. And for sure, the heat generation of ultrasonic will increase the efficacy of the irrigant. In endodontics, we seek success. Not only success, but a long-term success. That's why we need to develop a feasible, teachable, repeatable protocol for irrigation. During shaping, sodium hypochlorite is used during instrumentation and between each files, and at the time of the step couldn't be calculated correctly, so we can't consider this time in irrigation protocol. We need to know that the final irrigation protocol started after finishing shaping phase, so we can easily define the volume of the irrigation, the time, and the activation process. The final flush protocol involved the use of hypochlorite with EDTA and to separate between them using distilled water. Hypochlorite should be refreshed each 30 to 40 seconds to avoid buffering to the solution. The process of interchanging irrigant solution should be repeated 4 to 5 times. So it's about 10 minutes in single-rooted tooth and about 15 minutes in multi-rooted teeth. After good cleaning and disinfection to the canal, drying the canal, the space need to be sealed to avoid reinfection in the process known as obturation step. Bacteria present everywhere around the canals, in periapical area, in periodontium, and in the oral cavity. So we need to fill all the cleaned spaces to prevent re-entry or re-attack by microorganisms. So the role of obturation is to seal to prevent reinfection. Here you can see failure in root canal treatment, not only because of poor obturation, but because of poor treatment. So good obturation alone can't guarantee success of root canal treatment. The whole treatment need to be done in a proper way. If you look here at the preoperative radiograph, you can see a furcation lesion. And if the dentist who did the treatment treated 2 canals only in mesials and 1 or 2 in distal, still the treatment will end up by failure because we have here a middle mesial canal and the furcation canal originating from the middle mesial canal. That's why it is very important to do all the treatment starting from the axis to the final restoration in a proper way to improve the outcome of the treatment. In 2007, in the systematic review about the outcome of primary endodontic treatment, the author showed that 4 conditions would improve the outcome of the treatment, including the preoperative absence of periapical radiolucency, root filling with no voids, root filling extending to 2 mm within the root apex, and for sure satisfactory coronal restoration. So 3 of these factors are related to the quality of the seal. Number 2, filling with no voids, filling extending 2 mm within the radiographic apex, and the coronal restoration. In this retrospective comparative analysis, comparing the effect of obturation techniques on prognosis of endodontic therapy, it shows that the technique of obturation wouldn't matter, but the good quality of obturation would improve the outcome of the treatment. Here you can see failure of different reasons, missed anatomy, short obturation, and for sure improper cleaning and shaping. So at the end we have a biological failure. Another case of failure that I want to show you. What was interesting in this case that the case looks good radiographically in terms of shaping and for sure obturation. Even with mesial shaft, treatment still looks good, but clinically situation was different. Here, after removing the old restoration, you can see remnant of pulp tissue and remnant of microorganism in a mesial and distal roots canals. And in the mesial isthmus, you can clearly see remnant of pulp tissue. Here is a case after cleaning the canals and removing all remnant of pulp tissue in a proper way. And here is a case after obturation. You can appreciate the presence of mesial isthmus in the mesial root and lateral canal in the distal root. For sure, we can anticipate good prognosis after providing good quality treatment. Another case of retreatment. In the preapical radiograph, treatment looks good, but still we have a preapical lesion related to the mesial root. In the CBCT, the mesolingual canal obturation looks short. It looks more like an obturation error rather than neglection from the operator. Here is a case after obturation, mesial canals well cleaned, well filled, same for distal canal. This way we can anticipate good prognosis and healing to the mesial lesion after providing a good quality treatment. And please always remember that dead space inside root canal system is a best residence for microorganisms. That's why the seal is very important. Till today, we still rely on 𝗏𝗏𝘀𝗀 and sealer for the obturation process. Whatever technique we are using, called lateral compaction or word compaction, we still use 𝗏𝗏𝘀𝗀 and sealer. But if we are talking about technique steps, we have like basic rules that we need to apply for most obturation techniques involving master cone selection, canal drying and sealer application, filling the apical portion of the canal, complete the fill, assessing the quality of the fill, and finally the coronal restoration. 2 conditions we need to select the master cone. First, the master cone should be reaching to the working glands. And second, we need to have a good true tug back. And here we need to differentiate between true tug back and false tug back. In true tug back, we need the cone to be fitted at the apical third so we can feel resistance while we're removing the cone. However, in false tug back, the cone is fitted more in the middle or the coronal portion of the canal. So after cutting the coronal in the middle portion, no tug back. So there is a high possibility of pushing the master cone beyond the apex and also leakage around the master cone at the apical third. In case of false tug back, you might need to try less taper the master cone of the same apical diameter or simply increase the mid-root preparation diameter. One more important step is disinfection of 𝗏𝗏𝘀𝗀 cones. We can do disinfection of 𝗏𝗏𝘀𝗀 by soaking the cone in full strength sodium hypochlorite for 1 minute or 1 minute soaking in chlorhexidine gluconate 2%. I would prefer the chlorhexidine gluconate 2% for 1 minute because sometimes sodium hypochlorite for longer time will change the properties of 𝗏𝗫𝗀, and also sometimes it affect the bonding between 𝗏𝗫𝗀 cones and the sealer and the dentine wall. The lateral compaction technique is a commonly used obturation technique, especially between beginners, but it has some disadvantage, like possibility of induced crack formation. Mostly it has single cone at the apex, it is time consuming, more amount of sealer inside the canal, so higher possibility of leakage, and for sure poor adaptation of the root canal filling material to irregularities. Here are some cases that I did in the past using lateral compaction technique. However, it looks good radiographically, but I'm sure that some of them ended as a single cone obturation. On the other hand, these filled lateral canals are mostly filled with sealer. If you are speaking about complex anatomy, like C-shaped canal, for sure lateral compaction technique is not the technique of choice. However, it's not wrong, but we have other more indicated techniques for 3D filling of such complex system. The continuous wave compaction technique is considered the gold standard technique for obturation, and it's already proved that it is less time consuming and we have better adaptation to canal walls along with 3D filling to irregularities and isthmuses. This is the way I'm doing continuous wave compaction technique. I'm showing this case of maxillary first molar with a confirmed canals of MB1 and MB2. After sealer application, master cone insertion, using heat carrier, I'm cutting at orifice level, down packing the master cone shorter of the working length at about 5 mm. You can see here 𝗏𝗫𝗀 is coming out from MB2. Injection of warm 𝗏𝗫𝗀 into middle portion of the canal. Filling the coronal portion, then compaction using suitable plugger. Now, mesial canals filled in continuous wave compaction. Same steps in distal buccal canal, cutting at orifice level, compaction, down packing shorter of working length by about 4 to 5 millimeters. Compaction, pack filling to mid-root portion, and here pack filling to the coronal 1/3. Same steps for the palatal canal. Here I'm using a larger plugger or larger heat carrier because already canal was wide. Compaction, filling to the middle third, compaction, and here's the coronal 1/3. The technique is widely used by professionals, and we have very nice results and outcome from the technique, especially when we're dealing with complex anatomy and splitted canals. We have some limitation of the continuous wave compaction technique, like if the technique is improperly done, we have possibility of leakage. Leakage as a result of shrinkage of 𝗏𝗫𝗀 upon cooling and shrinkage of sealer upon setting. Also, in cases of long canals, it's quite difficult to reach with a heat carrier 5 mm shorter of the working length. So mostly in long canals we have a single cone at the apex, and it is not recommended with sealers which is not bioceramics. Another situation is the canals with severe curvature or canals with multiplanar curvature. The heat carrier tip will stuck at the first curvature, ending the treatment with a single cone apically. What about cases with patient with limited mouth opening in cases of time limitation or in case of apparent anatomy. So why not to make it more simple using a single cone obturation technique? No, not this cone. Yes, this one. The sealer-based obturation technique became widely used technique globally. It's called also sealer-dependent obturation because mainly we depend on sealer to fill spaces. We use 𝗏𝙗𝗀𝗃 cones as a plunger to push the sealer in the space for three-dimensional filling and also to facilitate the treatment, acting as a core for filling removal. The sealer most commonly used in a premixed formula, so it's a very easy technique to implement clinically. We have some well-known advantage to bioceramic sealer like the biocompatibility and the antibacterial action. It's osteogenic, also it's osteoinductive and osteoconductive. It's highly radiopaque. The material is expanding upon setting, giving proper seal, and one more advantage is the chemical bond to PC-coated 𝗏𝙗𝗀𝗃 and the chemical bond to dentine. We have another type of bonding to dentine called the micromechanical bonding. I'll show it also in next slides. Here is the hydration reaction of the material, which shows its bioactivity and how it's chemically bound to root canal dentine. The calcium silicate plus water, as it is a hydration reaction, so it requires moisture. The result is calcium silicate hydrate gel and calcium hydroxide. And here we can understand the antibacterial action and the high pH of the reaction. With the phosphate ions from the body serum or surrounding structure, we will have the formation of hydroxyapatite. But what about drying the canals, intentional extrusion, and interaction with dentin? About drying the canal, no need to dry the canal completely as the material requires moisture to set. However, some studies show that bioceramic sealer can set even in absence of moisture inside the canal. Regarding the intentional extrusion, it is not recommended. However, we have favorable reaction from the body, but filling material should be limited to the root canal space, so better to avoid intentional extrusion or sealer puff. If we are speaking about interaction with dentine, we have chemical bond with dentin, and as we described in the hydration reaction, also we have the micromechanical bonding because bioceramic sealer has nanoparticles, so it's so small and it can penetrate into internal tubules, forming what we can call sealer tags. Here we can see filled isthmuses with bioceramic sealer, and here's the difference in cross section between continuous wave compaction technique and bioceramic sealer obturation. More sealer and less 𝗏𝙗𝗃𝗃 with bioceramic sealer obturation. However, with continuous wave, we can appreciate the presence of warm 𝗏𝙗𝗃𝗃 into the isthmuses. Here are some cases that treated with bioceramic sealer as obturation technique. And here we can see fast healing in cases where bioceramic sealer obturation technique was used. Simply on this model, I'll choose a bioceramic sealer obturation technique with single cone. No need to have a good tug back because it's sealer dependent obturation, but for sure we need the master cone to be reaching to the working lens. We introduce the bioceramic sealer in the mid portion of the canal. Make sure that the tip is free in the canal, not locked. Sometimes we have a little amount of sealer on the nozzle of the needle. We can put it on the master cone. Now companies improve the quality of the tip so it is minimal waste. Then introduce the master cone 𝗏𝙗𝗃𝗃 with the sealer into the canal. As you can see, it acts as a plunger and it pushes the sealer into the spaces. With the heat carrier, just cut at the orifice level, and with a plugger you can gently compact the master cone. This is a case of large lesion related to lower 4 anterior teeth. It was a long-standing lesion, so after sensibility test, the 4 teeth respond negatively, so they were necrotic. And then we decided to do root canal treatment to all 4 anterior teeth. Here are selections from CBCT to evaluate the actual size of the lesion. And here is a case after treatment. Canals were obturated with bioceramic sealer and 𝗏𝗏𝗀𝗃. And we can see here that within 10 months, a very nice healing of the big lesion and hard tissue formation to fill the defect. And this is a 10 months CBCT follow-up. What about bioceramic sealer and heat? Actually, we have problem if we use the bioceramic sealer with heat, because physical properties will be affected. Change in setting time, usually a decrease. Change in viscosity. Also, decrease in adhesion to the dentinal wall and decreasing flowability of the sealer. And this is the most important one. So, decreasing the temperature of heat carrier looks mandatory if we are going to use the material in continuous wave compaction technique. We call it a modified heat technique as described by Alfredo Londolo. In the market now already we have a heat-friendly bioceramic sealer that can withstand high temperature. Let me show you this case of retreatment to mandibular second molar with a C-shaped canal configuration. Here, after removal of old restoration, now we are exploring the old 𝗏𝗏𝗀𝗃 in the pulp chamber. Some 𝗏𝗏𝗃 were inserted as single cones, so I am moving using a micro tweezer. With ultrasonics, while coolant is open, I'm cleaning the pulp chamber. Here you can see the C-shaped configuration. Using a larger taper file, I started to remove all the 𝗏𝗏𝗃𝗃 from the distal portion of the canal. And you can see here some pus secretion in the isthmus. Using ultrasonics with flashing, removing the remnant of 𝗏𝗏𝗃𝗃 from the pulp space. Exploring the missed anatomy using a DG16 probe, and you can see that the missed canal was already vital. Bleeding in the isthmus. Glide path preparation to the missed canal using the file size 17/4. Stroking motion with passive insertion to the file into the canal. Cleaning the isthmus using ultrasonics. This kind of cases is very challenging in terms of cleaning and disinfection, and also in terms of obturation. Good irrigation with sodium hypochlorite. Then activation to sodium hypochlorite using the ultrasonic. To allow deep penetration of irrigant deep into the dentinal tubules. And as long as we're going deep into the canal, I'm relying more on sonic activation just for safety. Final flush. After drying the canal, I am putting my bioceramic sealer into the canals For sure, some moisture may be remaining into isthmus area. That's why bioceramic obturation technique is preferred in this kind of cases. Here is the bioceramic. Insertion of the master cones. In this case, I used the passive lateral compaction technique for filling the spaces. Without any use of spreaders, I'm just using more cones of 𝗏𝗀𝗃𝗀 to push sealer more in the spaces. With heat carrier on low temperature, I'm sealing off the master cones. Then compaction using suitable plugger. Master cone in the mezd canal. Cutting the master cone at orifice level. Compaction using suitable plugger. And here is the case after completing obturation, and you can see that we have nicely filled C-shaped canal. Now you can see filled main canals, and the isthmus also is filled thanks to the passive hydraulic condensation using bioceramic sealer. This is what we are calling 3D cleaning and 3D obturation. Another case of retreatment to maxillary second molar. From the preoperative radiograph, we can see preapical lesion related to the mesial aspect of the tooth. With deep look, with more inspection to the radiograph, we can also see possibility of mezd anatomy. Here is the access cavity after removing the old restoration. We can clearly see the site of mezd anatomy, and it was very interesting to find another mesiopalatal canal in this molar. Here I started to remove single cones using a micro tweezer to avoid cutting it by rotaries and leaving remnant into the root canal system. Some 𝗏𝗀𝗃𝗀 cones removed as one unit by rotaries, and this is cleaned buccal canals, and here are palatal canals also cleaned. Now I'm showing you injection of bioceramic sealer into the palatal canals, and we can clearly see filling of the isthmus in between the two canals. And here is the case after obturation and filling to the canals. And this is the radiographic workflow. In the palatal root, you can see a filled island between the two palatal canals, thanks to the passive hydraulic condensation using bioceramic sealer to allow sufficient 3D obturation to the root canal space. This is the last case for today. Root canal treatment to tooth number 24 with symptomatic irreversible bites and normal periapical area. Before showing you how we manage this case, I want to describe to you also the intracanal heating to irrigation concept. Studies already proved that warming sodium hypochlorite inside the canal enhanced pulp tissue dissolution and resulted in cleaner canals. Other studies showed that final irrigation protocol based on intracanal heating of sodium hypochlorite at 180 degrees with system P heat source showed to be better than preheated sodium hypochlorite at 50 degrees in obtaining cleaned canal walls. After proper access and shaping, this is the way I'm doing intracanal heating to irrigation. Adjusting the temperature to 180 degrees on the E-heater with intermittent period of cooling. Here you can see evaporation of hypochlorite, also the surface tension of the liquid decrease, resulting in better penetration of irrigation into narrow areas. After proper cleaning and final flush protocol, now it's obturation step. I am injecting bioceramic sealer into the canal, the palatal canal, the buccal canal. Here is the master cone after proper selection, confirming it's reaching to the working length. Now I need to decrease the temperature to 130 degrees to avoid overheating inside the canal, not to affect the properties of bioceramic sealer. This is a modified heat technique. In a quick stroke, I'm removing the coronal portion of 𝗏𝙗𝗀𝗃, then compaction using suitable plugger. The other canal, same steps. Heat carrier, 130 degrees. Quick cutting to the coronal portion or point of resistance with the plugger. Compaction. You can do the cut 2 times, but at 130 degree temperature. Now backfilling the coronal space using warm 𝗏𝙗𝗃𝗃. The buccal canal. And here's the case after obturation. This is the post-operative radiograph showing well-filled canals in modified heat technique with 𝗏𝙗𝗃𝗃 and bioceramic sealer. And here is the radiographic workflow. Last but not least, when I speak about obturation and 3D sealing, I can't ignore confirming the importance of prompt final coronal seal. Coronal seal is very important to avoid leakage from temporary filling through oral cavity, especially over long period, as I can't consider completion of endodontic treatment until the tooth is restored to function.
That was my today's presentation. I would like to thank you all, and if you have any question, please write it in comments and I will be happy to answer you. Thank you and see you soon.